So, about patients, the patient with medically unexplained physical symptoms. So, let's talk about them. Medically unexplained symptoms, or symptoms where no cause can be found despite adequate investigation, are a common clinical problem, representing around a third of medical outpatient appointments and a large proportion of primary care appointments. Patients with such symptoms are often stigmatized by healthcare providers, with their genuine difficulties being labeled fat folder syndrome, all in the mind, or the worried well. Okay, fat folder syndrome, all in the mind, or the worried well. Understanding the psychiatric disorders leading patients to have unusual physical symptoms or an abnormal response to physical symptoms is invaluable for all junior doctors. Let's talk about some definitions and clinical features. A structural or physical cause should always be considered in response to reported physical symptoms. However, in certain cases, the reported symptoms are medically unexplained. That is, they do not correspond to or are clearly not typical of any known physical condition. They are associated with an absence of any physical signs or structural abnormalities and are associated with an absence of any abnormalities in comprehensive laboratory imaging and invasive investigations. Medically unexplained symptoms represent a large and diverse group of symptoms and underlying difficulties. It is likely that some disorders of which no medical cause can be found are still secondary to physical etiology, subtle presentations of a disorder yet to fully manifest, or a vanishingly rare genetic disorder, toxin or occult infection which can never be detected. Some symptoms are recognized to arise as part of common syndrome without associated structural abnormalities but with unclear etiology. These are generally now termed functional disorders, for example, fibromyalgia, irritable bowel syndrome, or dissociative disorders. Some symptoms are associated with undue distress, causing a high degree of anxiety and impairment despite reassurance. These somatoform disorders are the focus of this chapter. In DSM-5, we don't have somatoform disorders anymore. We have somatic symptom and related disorders. Okay. It is worth noting that even though no structural or physiological disease has been identified, it does not mean that one does not exist. It may remain undiscovered. Thus, far to medical science. For example, epilepsy, migraine, multiple sclerosis, and stomach ulcers were historically considered functional illnesses. Here we have a table that lists of what are currently termed functional disorders. We have some functional disorders like, cardiovascular, like atypical chest pain. We have respiratory functional like hyperventilation, gastrointestinal like irritable bowel syndrome, neurological like dissociative seizures, weakness and sensory symptoms. Dissociative weakness or dissociative sensory symptoms. We have fibromyalgia in rheumatology, and we have chronic fatigue syndrome as infectious disease. So, it is also worth noting that many patients with medically unexplained symptoms will be reassured by normal investigations or an explanation that they are functional symptoms which are likely to get better. Those patients who are unable to accept reassurance may have a somatoform disorder. Let's talk about somatoform disorders. Somatoform disorders are a class of disorders where patients are unduly concerned about physical symptoms or illness. Obviously, it is normal to be concerned to some extent about physical symptoms and what they may indicate. However, in somatoform disorders, patients remain concerned even when examination and investigations show no detectable structural or physiological abnormalities, or show some abnormalities that are insufficient to account for the severity of the patient's response. Patients are unable to accept reassurance and remain anxious and disabled by their physical symptoms. In somatoform disorders, symptoms are not under voluntary control. They occur unintentionally, as opposed to the intentional fidgeting or production of symptoms in factitious disorder and malingering. Patients may have a comorbid physical health condition like mild asthma, but feel unduly preoccupied about the risks for this to be the point of having regular episodes of hyperventilation. The commonest somatoform disorders are somatization disorder, hypochondriacal disorder, and body dysmorphic disorder. In DSM-5, we don't have somatization disorder anymore. We have somatic symptom disorder. We don't have hypochondriacal disorder anymore. We have illness anxiety disorder. And body dysmorphic disorder is within the chapter of OCD. Anyways, somatoform autonomic dysfunction and persistent somatoform pain disorder are now generally subsumed within functional disorders and are not covered further here. All of these diagnoses are undergoing classification revision, with a move away from the requirement of medically unexplained symptoms in the Diagnostic and Statistical Manual of Mental Disorders, DSM-5, instead emphasizing on an abnormal response to symptoms, medically explained or not, and the use of the term bodily distress disorder in place of somatoform disorder is bodily distress disorder in place of somatoform disorder in the most recent draft of International Statistical, which is the ICD-11. Communication. It's important to acknowledge that even though no physical pathology has been found, the functional impairment and distress caused by somatoform disorders is genuine, and that the symptoms are neither under conscious control nor are they being vaguened. Empathic acknowledgement and explanation can be very therapeutic in itself. Dismissing a patient by telling them that their symptoms are all in your mind is unhelpful and potentially harmful. What about somatization disorder? The central features of somatization disorder are multiple recurrent and frequently changing physical symptoms with the absence of identifiable physiological explanation. These include gastrointestinal, like nausea, vomiting, diarrhea, constipation, food intolerance, and abdominal pain; sexual or reproductive, like loss of libido, ejaculatory or erectile dysfunction, irregular menses, menorrhagia or dysmenorrhea; urinary symptoms like dysuria, frequency, urinary retention, and incontinence; and the neurological symptoms like paralysis, paresthesia, sensory loss, seizure, difficulty swallowing, impaired coordination or balance. To meet diagnostic criteria, patients should have numerous symptoms from almost all these somatic groups, not just one or two isolated symptoms. For the diagnosis of somatization disorder, the ICD-10 suggests that all the following be present: at least 2 years of symptoms with no physical explanation found, persistent refusal by the patient to accept reassurance from several doctors that there is no physical cause for the symptoms, and some degree of functional impairment due to the symptoms and resulting behavior. Most patients with somatization disorder will have a long history of contact with medical services, during which numerous investigations may have been conducted. This often results in iatrogenic disease with physically explained symptoms, abdominal adhesion from frequent exploratory surgery. Due to frequent courses of medication, these patients are often dependent on analgesics and sedatives. Okay. What about hypochondriacal disorder? In hypochondriacal disorder, patients misinterpret normal bodily sensation, which had them to believe that they have a serious and progressive physical disease. These patients tend to ask for investigations to definitively diagnose or confirm their underlying disease. However, despite repeated normal examination and investigations, hypochondriacal patients refuse to accept the reassurance of numerous doctors that they do not suffer from a serious physical illness. This is in contrast to somatization disorder, where patients tend to seek relief from their symptoms. What about body dysmorphic disorder? Body dysmorphic disorder, or a dysmorphophobia, is a variant of hypochondriacal disorder in which patients are preoccupied with an imagined or minor defect in their physical appearance. The symptoms should not be better accounted for by another disorder, like concerns regarding weight and body shape. These are usually more accurately attributed to an eating disorder. This imagined defect or deformity can concern any part of the body: crooked nose, ugly hands, and so on. The preoccupation causes significant distress or impairment in functioning. The psychopathology of both hypochondriacal disorder and body dysmorphic disorder takes the form of an overvalued ideas. The belief is not delusional because patients are open to some explanation and their fears can be allayed, at least for a short while. Actually, that's not the difference between body dysmorphic disorder and delusional disorder in DSM-5. The difference is just about the nature of the ideas, because some body dysmorphic disorder patients would be delusional, but it's about the shape of the body or some parts of the body, while delusional disorder is about sensation or functioning. So at least that's the difference in DSM-5, not here. Okay. It's not about explanation or not. A persistent delusional disorder, which is somatic delusional disorder, is diagnosed if the belief is held with delusional intensity. This is in ICD-10. What about functional, conversion, and dissociative disorders, as differential here? These three types of disorder are closely related and their classification is evolving rapidly. Conversion is a psychoanalytical term that describes the hypothetical process whereby psychic conflict or pain undergoes conversion into somatic or physical form to produce physical symptoms. The DSM-5 uses this term interchangeably with functional neurological symptom disorder. Functional neurological symptom disorder. Although a recent stressor is not required for the diagnosis, whereas ICD-10 considers these to be dissociative disorders. This book describes these in chapter 14. We've talked about that. Okay. What about factitious disorder and malingering? Both factitious disorder and malingering differ from somatoform disorders in that physical or psychological symptoms are produced intentionally or weakened. Patients may give convincing histories that fool even experienced clinicians and often manufacture signs like warfarin may be ingested to stimulate bleeding disorders, insulin may be injected to produce hypoglycemia, urine may be contaminated with blood or feces. Certain patients vein psychiatric symptoms such as hallucinations, delusions, depression, or dissociative symptoms. These patients can go undetected and may receive large doses of psychotropic medication, as well as visioning physical or psychiatric illnesses. These patients tend to provide a fluent, plausible account for symptoms described as pseudologia fantastica, pathological lying. Pseudologia fantastica, of course, okay. Okay, what about factitious disorder or Munchausen syndrome? The central feature of factitious disorder is focus on the primary internal gain of assuming the sick role. They aim to be cared for like a patient, usually in hospital. Although symptoms are weakened, it is important to understand that this care-seeking behavior is usually a manifestation of psychological distress. Although the terms are still used synonymously and interchangeably, Munchausen syndrome refers to a subgroup of patients with factitious disorder who travel between hospitals and care providers. Peregrination, often giving different names and details. The syndrome's name derives from Rodolphe Eric Raspi's literary character, which is Baron Munchausen, as known teller of fantastic and implausible stories about his travels and adventures. Okay, what about malingering? Malingering patients focus on secondary or external gain of the secondary consequence of being diagnosed with an illness, avoidance of military service, evading criminal prosecution, obtaining illicit drugs, obtaining benefits or compensation. Okay, what about Munchausen syndrome by proxy? This is a form of abuse where a carer, classically a parent, will seek help of fabricated or induced symptoms in a dependent, classically a child. The psychological aim of the carer is for the dependent to be cared for like a patient. The induction of a factitious disorder can be dangerous, for example, covert poisoning, and once a diagnosis has been made, the dependent should be removed from the direct influence of the carer, and relevant authorities, most often child adult protection agencies, alerted. The affected carer should be offered psychiatric help. However, because the disorder is rare, little is known about effective treatment. So, about differential diagnosis. The differential diagnosis for patients presenting with an abnormal response to physical symptoms is shown in the box. Okay, the first differential to consider is the undiagnosed unknown medical condition, or undiagnosed non-medical condition, like insidious multi-system disease. So you should consider that there is unknown medical condition that we didn't diagnose, or there is a medical condition but we cannot diagnose yet. Okay. Or functional disorders, also known as dissociative disorders or convergent disorders, somatoform disorders like somatization disorder, hypochondriacal and body dysmorphic, factitious disorder, malingering, and other psychiatric conditions like anxiety, mood, and psychotic disorders. Let's go through this algorithm for medically unexplained symptoms. For medically unexplained symptoms, if these symptoms are because physical disorders sufficient to cause symptoms adequately excluded, if physical disorders are excluded, we go further. If not, further examination and investigation would be done for, to diagnose the patient. If we can exclude physical disorders, we ask ourselves if these symptoms are secondary to another psychiatric disorder like fatigue and depression, paresthesia and anxiety, somatic hallucination in psychosis. If yes, so it's because of the other psychiatric disorder, and we treat that. If these symptoms, if there's positive evidence of functional disorder, for example, Hoover sign in neurological symptoms, pain relieved by defecation in irritable bowel syndrome, tenderness at specific points in fibromyalgia, so yes, you diagnose the patient with the disorder accordingly. If there is abnormal response to symptoms, undue concern over symptoms, so the concern is about the symptoms, here we are talking about somatization disorder. And in DSM-5, somatic symptom disorder, if the complaint is about the symptoms. If the concern about the underlying diagnosis with minimal symptoms, we are talking about illness anxiety disorder. Here they call it hypochondriacal disorder. Or, somehow. If the concern is about the appearance, we are talking about body dysmorphic disorder. Okay, what about if the symptoms are fabricated? So if it is to gain the sick role, so we are talking about factitious. If the goal is to gain secondary gain or external gain, so we are talking about malingering. Okay, an underlying physical condition should be ruled out when patients present with physical symptoms. Somatization disorder can resemble insidious multisystem disease such as systemic lupus erythematosus, multiple sclerosis, acquired immune deficiency syndrome, hyperparathyroidism, occult malignancy, and chronic infections. Physical complaints often occur in the context of other psychiatric conditions. Patients with schizophrenia may have somatic delusions or visceral somatic hallucinations. However, the explanation of these symptoms is often quite odd, and there are usually other psychotic symptoms accompanying the physical complaints. Individuals with depressed mood often present with numerous somatic complaints. These tend to be episodic and resolve with the treatment of the depression. Patients with panic disorder have multiple somatic symptoms while having panic attacks, but these resolve when the panic subsides. Patients with generalized anxiety disorder may also have multiple somatic preoccupations, but their anxiety is not limited to physical symptoms. Conversion and dissociative disorders like motor disorders, psychogenic, non-epileptic seizure can present with neurological symptoms without any evidence of an organic cause. However, these symptoms are usually clearly defined and isolated as opposed to the ill-defined multiple symptoms of somatization disorder. The difficulty in distinguishing other mental disorders from somatization disorder is illustrated by the observation that at least half of patients with somatization disorder have another coexisting mental illness. Okay, here we have a red flag. Somatization disorder usually has its onset in early adult life. The onset of multiple physical symptoms late in life is more likely to be due to a physical illness. For assessment, starting from history, the following questions may be helpful in screening for somatoform disorders on mental state examination. Do you often worry about your health? Are you bothered by many different symptoms? Are you concerned you may have a serious illness? Are you concerned about your appearance? Do you find it hard to believe doctors when they tell you that there's nothing wrong with you? So these are the questions. What about examination? A thorough physical examination with special focus on the presenting problem is imperative when dealing with somatoform complaints. About investigations, clinicians dealing with patients with somatoform disorder need to investigate physical complaints judiciously. It is important to take care all symptoms seriously. Yet, excessive and needless investigations to placate an anxious patient can result in a vicious cycle with worsening of symptoms. Invasive investigations can result in iatrogenic harm. See Chapter 23 for guidance and management. We'll talk about it later. So let's see the case. Mrs. SD, a 32-year-old mother of 3, had consulted her general practitioner at least once every 2 weeks for the past year. Her GP had known her for just over a year since she moved to the area after an acrimonious divorce. Her medical history, part of which was obtained from her previous GP, was substantial, and her health difficulties had precluded her from employment. At menarche, she was diagnosed with dysfunctional uterine bleeding and dysmenorrhea. Extensive investigations, including 3 exploratory laparoscopies, revealed no physical cause for persistent upper abdominal pain with alternating diarrhea and constipation. 3 years ago, Mrs. SD presented with urinary frequency and dysuria. Exhaustive investigations, including cystoscopy, urodynamic studies, and radiography, were all normal. She had also been referred to various specialties, including a rheumatologist due to chronic neck pain that she had described as the pain that has ruined mine and my kids' life, Again, physical examination and investigations revealed no abnormalities. Mrs. SD was taking up to 30 codeine tablets daily and could not sleep without 2 different types of sleeping tablets. So let's go to the discussion. So Mrs. SD has a long history of multiple recurrent, frequently changing physical symptoms for which no physical causes have been found, despite extensive investigation. She is unduly distressed by her symptoms. For example, describing pain as ruining her life. Her functioning has been impaired, and this has possibly impact on her child's lives because she is focused on symptoms, not the idea that she has a serious and progressive illness. Mrs. SD has somatization disorder, of course, as opposed to hypochondriacal disorder. As is typical, Mrs. SD has a secondary, possible iatrogenic substance misuse problem, codeine and sleeping tablets. It would be important to exclude other mental illnesses such as depression and anxiety as causative factors. If there was evidence that Mrs. SD intentionally produced or feigned her symptoms, then factitious disorder or malingering should be considered. Okay, now you can go to chapter 23 to read about somatoform disorder and their management. But let's go to the chapter summary. Medically unexplained symptoms are common in all fields of medicine. In somatoform disorders, patients have an abnormal response to physical symptoms. In functional dissociative disorders, the normal integration of consciousness with cognition is disrupted, leading to disrupted sensory perception and motor control. In factitious disorder and malingering, patients feign physical symptoms. هذا والله تعالى أعلم وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.